So if you look over here in this particular patient, you will see that this is a fibroid on the right side. You look at this myometrium, it looks pretty normal. But as I move, yeah, it's working in this mode, I don't know if it's not working in the other mode. But as I move to the left, you will see posteriorly, there is this area which looks typically adenomyotic. Cystic spaces lined by hyperechoic. Look at this shadowing. So this is focal adenomyosis, and this is really rare. In contrast, you look at focal adenomyosis that is surrounded by hypertrophy, and that is called an adenomyoma. And adenomyoma is in fact much more commonly seen than focal adenomyosis. And you can see you cannot even measure this. It becomes so difficult because you cannot see the margins of this lesion. I'm going to go back to my other modality now. Sorry about this. Yeah. Yes. So if you look at this, this is an adenomyoma, and this was focal adenomyosis. And oh, now it decided to move. Okay. And I'm going to stop this now. So that is the focal adenomyosis, and that is an adenomyoma. And very often this adenomyotic myometrium, if you look at it, you will see that it is actually protruding into the endometrium. So very often you see that this adenomyomas or adenomyotic myometrium can indent the endometrium. Now, diagnosing adenomyosis has only one big challenge, and that is to be able to distinguish it from fibroids, because management is extremely difficult. Very often you see patients who have been taken up for laparoscopy and they're just not getting the gains because it's really not a fibroid, it's an adenomyoma or adenomyosis. So what helps us distinguish? The first thing is the uterine body may be regular or lobulated with fibroids, whereas in adenomyosis, if it's enlarged also, it is typically a globular shaped uterus. Secondly, fibroids have well-defined margins, as you can see here, in contrast to adenomyosis, where the margins are poorly defined. You see internal linear shadowing in both these lesions, but what is very typical of fibroids is the presence of these edge shadows because they are well-delineated masses. Now, I mean, all textbooks don't give this, but if you look at the difference between these two, you realize in fibroids, the shadowing is much coarser, thicker, so it's called stripy shadows, whereas in adenomyosis, it's typically more fine, and that's why it's called rain in a forest appearance. Secondly, if you look at the echogenicity of this fibroid itself, it's quite different from the myometrium. Unlike adenomyosis, it resembles the same sort of echogenicity as the rest of the myometrium, whereas fibroids can be very different echogenically. They're typically more hypoechoic. So these are other features that can help you distinguish. Then, of course, Doppler, we know that peripheral flow and circumferential flow is what we see predominantly in a fibroid, whereas in adenomyosis, it's intralesional flow, it's through and through. And this is because this is an infiltrating lesion, whereas this is a lesion that displaces the normal myometrium. So this is why we see the circumferential flow, but this is not all that simple, because sometimes you see very cellular fibroids, and then it can be confusing, and adenomyomas may show some peripheral flow. So what happens, is there some way of finding out the difference between intralesional flow in a fibroid and in an adenomyoma or adenomyosis? In a fibroid, you may see it in any direction, but in an adenomyoma or adenomyosis, this direction towards the endometrium. So there is some difference even in the intralesional flow between an adenomyoma and a fibroid. And of course, if you see an endometrium running through a lesion, you know that it cannot be a fibroid. You cannot have the endometrium running through. Fibroids may distort any place where there is long-standing endometrium. So you see it in adenomyosis, you see it in endometriomas, you see it in deep infiltrating endometriotic nodules, etc. So this is how we distinguish the two, and now we will move on to our next topic, that is endometriosis. Now, endometriosis, like I said, I told you, superficial endometriosis is commonest and most difficult to pick up. But yet, if you look at, and I'm totally in love with ultrasound, as you might know. Ultrasound is the diagnostic modality of choice to pick up displaced endometrium, including endometriosis. And ESHRE in their 2022 guidelines have said that imaging is the gold standard now and not laparoscopy, because you cannot see below adhesions what's happening on laparoscopy. So let's start off with ovarian endometriosis. We know, all of us know, that these typical smooth, round, hypoechoic cysts with ground glass contents are classic of endometriosis. But what is very important is to remember that not all ground glass cysts are endometrious. In the premenopausal, yes, the majority are, but in the postmenopausal, the majority are malignant. So just because we see ground glass contents within a mass, it doesn't mean it is an endometrioma, and we should be very careful, particularly in postmenopausal ladies. And if you look at the walls of these endometriomas, you see they're very smooth, regular. You may see this is the hyperechoic foci that I was saying. They're very specific of chronic hemorrhage, and they're believed to be cholesterol crystals. They have a very high LR for an endometrioma, but they're only seen in 1/3 of endometriomas. And then, of course, we know the ovaries tend to be fixed. You see periovarian adhesions, loculated fluid. This is all very common. You may see the ovaries stuck. You see kissing ovaries and so on. But not always are these contents so clear. Sometimes you have some debris lying within an endometrioma. Here you have a clot. You know it's hyperechoic and avascular. And here was another patient who was diagnosed as a clot within an endometrioma. She was operated with partial cystectomy. The report came as endometriosis. She came back to me 2-3 months later, and I found this lesion, and I realized that they had interrogated this with Doppler, but with improper settings, and they had missed a malignancy. So whenever you see a hyperechoic area within a cyst with ground glass contents, make sure that you assess it carefully with Doppler, but with proper settings. Then we moved to superficial endometriosis. And for a long time, we thought that it is impossible to pick it up, but of late there have been a lot of articles showing that if you observe carefully the peritoneal surface of these pelvic structures, particularly with fluid in the pouch of Douglas, you may pick up hyperechoic projections, hypoechoic areas, small cystic areas. I didn't have time to put all the videos, flimsy adhesions, peritoneal pockets, etc. As you can see in this, sorry. Okay, so here you can see this. This is the, you can look at the serosal surface of the uterus, some turbid fluid. Can you see those hyperechoic projections, flimsy adhesions, peritoneal pockets? These are all features. And Dr. Matthew Leonardi, who will be coming, I'll talk about the conference that we're going to have. He's going to be coming. He's a pioneer in this work. And he has he's called it sonopodography. POD standing for fluid in the pouch of Douglas. They actually instance saline inside, and then they look at it. So nowadays, I feel if you're looking at a patient with infertility, it may be a great idea to see it around ovulation, because you may have some fluid in the pouch of Douglas where you can assess superficial endometriosis. You can look for ovulation. You can look at the endometrium also. When she comes to you first time for a scan, the best time is to do a scan around ovulation. Then we move on to deep endometriosis. Deep endometriosis we know is endometriosis infiltrating the peritoneum at least 5 millimeters. There's some controversy now whether it should be 5 millimeters or not. But this is the conventional definition. And why is this so important? Because this is a cause for a lot of distress to patients. And the sad part is it's often not diagnosed on ultrasound because the sonologists are not aware of the spectrum of what we see on ultrasound. And I think, I know many of you don't do ultrasound, but I think unless there's a demand from clinicians for quality ultrasound, this is going to happen. Even in our hospital, if you miss a fetal anomaly, the whole hospital, management, director, patients, lawyers, everybody's after us. But if you miss a malignancy, no big deal. That should not be so. I think there should be a pressure from clinicians saying this report is not optimal, please get me. That will push us to work harder to study better. So let's move on. It's a neglected entity. I have lots of patients who wept, who've gone to psychiatrists with pain which has not been diagnosed. And of course, it can affect the surrounding organs. You can get a hydrosalpinx, you can get hydroureters, lots of other problems with deep endometriosis. But most importantly, every clinician wants optimal planning of surgery. So if you anticipate DIE, you can get the appropriate consent. You may want to involve in a colorectal surgeon, a urologist, whatever it is. And we all know, of course, surgery is the best. So evaluate the patient well on ultrasound before you embark upon surgery. So how do these lesions look on ultrasound? They appear hypoechoic. This is rectal DIE, this is a bladder DIE lesion, and this is a vaginal DIE lesion. They appear hypoechoic, they have diffuse borders, they appear fusiform or nodular, they are firm, they may show some amount of shadowing because the natural progression of endometriosis is infiltration, inflammation, and fibrosis. So you see this fibrosis is what causes the shadowing, as you can see over here. The lesions tend to be tender and they're most of poorly vascularized. Sorry, let me drink some water. And of course, they're poorly vascularized. These lesions are typically solid, but sometimes they may be solid with cystic areas inside, and occasionally they are predominantly cystic. Whenever you see a lesion, like elsewhere in gynecology, you should measure it in 3 orthogonal dimensions, and remember these can be multiple, so if you find one, it's a good idea to search for other lesions elsewhere. Now let's look at, I'm not going to go through the entire spectrum, but large bowel DI is very commonly seen, and this is how it appears. This is the DI lesion. If you look at the normal anterior muscularis, you see a thin white line over here, and this separates the inner circular from the outer longitudinal fibers, and in the area of the DI, you see that the lesion, the whole anterior muscularis is thick, and this hyperechoic line is not seen. These lesions are almost always adherent to the uterus, and believe me, if you see a DI lesion of the rectum which is not adherent to the uterus, you can ask that patient, she will give you a history of surgery. I've had patients who've hidden their history of past surgery because they were married now, they didn't want the in-laws to know, and then I asked them, tell me honestly, did you have a surgery? And she said, yes, but don't tell them. I said, okay, because the DI lesion was not adherent to the uterus. So here, this lesion was not only adherent to the uterus, it was also adherent to the right ovary. Now this is another DI lesion. You can see it's very large. The anterior muscularis is 10.7 millimeters, whereas the posterior muscularis is just 1.4 millimeters. And this is the typical signature of the bowel. So you have the anterior muscularis and posterior muscularis. Within the muscularis, you have this hyperechoic area, which is a submucosa, and right in the center is the lumen lined by the mucosa. So remember, when you see what I very often have, I do a lot of training, and I have people who send me images saying, Madam, is this DIE? It's just something dark in the pouch of Douglas. Anything dark in the pouch of Douglas is not DIE. You need to be able to see the signature of the bowel. You need to be able to see the layers, and then one part of the anterior muscularis, or whichever area it is, should be a large solid tissue with poor vascularity, very often tender. Here you can see the lesions are typically not very vascular. A very interesting feature here is called the red Indian hairdress sign, and that is because there's infiltration into the submucosa and retraction of the submucosa because of fibrosis. So infiltration, retraction gives this red Indian hairdress sign. And when you have significant amount of retraction and fibrosis, you have these hyperechoic lines actually radiating out from the DI nodule, and I have found these very useful in picking up deep infiltrating endometriosis. So when you're doing a scan, you suddenly see these multiple hyperechoic lines running towards something. You just follow them and you will end up in that DI lesion. And this is called, because of its appearance, as a pull-up sleeve sign. They've got very interesting signs. And then you have a mushroom sign, and that is because the DI lesion has become almost circular because of retraction from the side. So you get these nice round mushroom-shaped lesions. Now, even if in every single patient, whether she's got endometriosis or not, we have to look for sliding sign. When you see a report from our department, it always has a sliding sign. We see whether there's a high sliding sign and a low sliding sign. And basically the sliding sign is sliding of the bowel behind the uterus. So you can see it's smoothly sliding, there's nothing stuck. So in this patient, I know the sliding sign is present. In contrast, if you look at this patient over here, when there is no sliding sign, you're wondering, your probe should always be in the anterior fornix, and you should apply pressure with your probe. And when it still doesn't happen, what you need to do is apply biome. So with your free hand, you try and ballot the uterus, so to see if there is some sliding of the bowel. So you can see in this patient, I did try, and you can see that's my free hand. Nothing, it just compresses the bowel and releases. The ovary was stuck, and this patient also had a small rectal DI lesion, which was the reason why she did not have this sliding sign. So remember, sliding sign has a very high LR for rectal DI, 23.6. So even if you don't see a DI lesion, every single report should tell the clinician, I'm seeing a sliding sign or I'm not, because it will give the clinician an idea that in this particular patient, the bowels are adherent to the posterior wall of the uterus. Now, rectovaginal DI is very often seen along with rectal DI. So many of the clinicians will send me a patient saying, I'm feeling some nodularity in the vagina or some, a mass in the vagina. And this is what happens. So this is the normal rectovaginal septum. Here you see there's a breach and the rectal DIE is adherent to the vagina. It's continuous with the vaginal DIE. The vagina here is thick, and we will see how whenever we see rectal vaginal DIE or cervical DIE, we always put gel into the vagina because it produces a beautiful standoff, and you can see the images well. So here you see I've introduced gel. This is the cervix. You can see the cervical canal. In the posterior fornix, on the left side, you see the vagina is normal. I'm going to stop this, sorry. Whether I can stop it there. No. So here you see this is the left side, it's normal, but on the right side, I don't know if you saw this, this is how the So on the right side, I want you to notice those hyperechoic foci within the vaginal DI. Can you see those? And that is the rectal DI behind it. And again on transverse section, the normal anterior fornix, the normal vagina, and in the posterior fornix on the right side, you see this thickened DI lesion. Now the last slide, associated findings in endometriosis. So there are certain features that are very commonly seen in endometriosis. One is tubal pathology, but unfortunately it's not easy to pick up an ultrasound. And the second is a ear-shaped or a question mark shaped or a comma shaped uterus. Normally retroflexion occurs at the internal os, but here retroflexion occurs at the mid-corpus, and that's what gives it its appearance. And another very interesting finding is a twisted uterus. So when you look at a long section, this is long section of the uterus, but when you rotate your probe and you're trying to see a transverse section or a coronal view, you'll see the uterus is deviated to one side. That is very, very typical because there is not only twisting anteriorly and posteriorly, but there's also lateral twisting because of fibrosis and deposits in the pouch of Douglas. Another interesting feature is the irregular serosal surface that you see in these patients because of adhesions of bowel and also adenomyosis. Now this, sorry, I'm going to go back. So this adenomyosis that is seen because endometrium is entering the myometrium not from the endometrium, but it's entering it from the serosal surface of the uterus because of chocolate cysts, because of deposits in the pouch of Douglas. So this adenomyosis affects only the outer portion of the myometrium, and this is called as FOAM. FOAM stands for focal outer adenomyosis of the myometrium, and this is a feature that this patient is very likely to have deep endometriosis of the posterior compartment. So to conclude, adenomyosis of course can be diffuse focal or you may see an adenomyoma. It's very important to be able to confidently differentiate it from a fibroid, and remember there's an entity called FOAM which is indicative of deep endometriosis. Now if you want more information, because I have only 20 minutes, you need to look, you can go through this article about how you should systematically report adenomyosis. And as far as endometriosis is concerned, for ovarian endometriosis, it's important to note that not all masses with ground glass contents are endometriomas. In superficial infiltrating endometriosis, remember, sonopodography, there are a lot of articles now, and maybe if we pay some attention and maybe with more prospective studies, we will know the role of sonopodography. Deep infiltrating endometriosis is unfortunately a neglected entity. We must think of DIE in patients with chronic pelvic pain and endometriomas, and I think if you're doing a surgery and you end up with something which you didn't expect, you should ask your sonologist what happened. You didn't tell me about this. Proper preoperative evaluation is very, very important. Patients with endometriosis, many of them come in with infertility for optimal planning of surgery. And this is a very interesting article, consensus paper, which is a fantastic read. I didn't have time to go through it, but it is a basic consensus statement on how to evaluate a patient with endometriosis. Thank you very much, but before I conclude, I want to invite you all to this conference in Bangalore, and even if you're not doing sonology, ultrasound, maybe you can tell your colleagues who are doing ultrasound to come in. This is May 3rd to 5th. It's in Sheraton in the Orion Mall. And we have a fantastic, these three are absolutely superb speakers. I've literally handpicked the best three that I like. She is, of course, got the gold medal for her contribution in gynae ultrasound. She's from Sweden. Antonia Testa has done amazing work in gynec oncology ultrasound, published the maximum number of papers, I don't know how many. And Matthew Leonardi does his own surgeries for endometriosis. and also does a lot. So he actually has people in training. He does the ultrasound in the OT and then tells them, look, this is what I saw on ultrasound and this is what we are seeing at surgery. And he's a really enthused young fellow and is an amazing speaker. So I welcome you all to this conference, and it's right here in Bangalore, and even if you're not doing ultrasound, I suggest you could share this with your colleagues. Thank you very much.
Thank you, ma'am. Like how adenomayosis is called is the vein of forest. We had the much needed vein in the CME today with your talk. Thank you so much. I request Dr. Vidyamani to give a token of appreciation to Dr. Mala. Yes, ma'am.
Hi, Dr. Shubha.
Hi, that was wonderful. It is so nice to listen to you. This is the first time I'm hearing about endometriosis from you. It has always been iota earlier. So thank you so much for the lecture. My one question was, and thanks for showing the Renovalius fascia. It is so wonderful to see that on TV, so well explained. And the idea of putting the gel in the vagina is really super. I think I've seen others also doing it. It's fantastic. Now, I just wanted to know, there are many instances where we get an ultrasound remark from the sonologist themselves that, asking for an MRI, if we send them a pre-operative assessment for endometriomas, because he as the surgeons are great into, of course we do the AMH levels, but we are great interested in knowing is what to expect, how much normal ovary to expect. So is MRI necessary, or what you can tell us about that?
So I want to know if you want to know what is the role of MRI in just assessing the ovary or the whole pelvis?
Only for endometrioma.
Only for endometriosis. Endometriosis. So I want to tell you, in fact, Dr. Suresh, all of you know in Chennai, we discuss very often, and he keeps telling me that the problem is MRI helps us see. We can see on ultrasound. The problem and where the hitch really is what does that thing mean? I'm seeing something, I don't know what it means. So what people do is to pass the buck on. This is what is typically done. The only time I think MRI will score above ultrasound in endometriosis is when you're seeing parametrial and deep parametrial invasion into the sacral plexus. So if you have a patient with dysmenorrhea, endometriosis, pain radiating down the leg, hip pain, those are the patients where I think we may not be able to do a good, and many of these are young women, we may not even be able to do a transvaginal scan. So if you cannot do a transvaginal scan in a young girl, another option is to do transrectal scan, but honestly I'm not very comfortable, and maybe I'm not good enough, or I have not have enough experience. So in an unmarried girl with dysmenorrhea, or in a patient where we can do a transvaginal scan, but her symptoms or our findings suggest there is deep parametrial invasion posteriorly towards the sacrum, I think that's where MRI definitely scores above us. And I actually send the patient, Dr. Madhavi Noori in Hyderabad has done a lot of work in women imaging and endometriosis, in fact in MRI in endometriosis. And she will also be there at the conference and will be speaking on this. So we in fact send the MRI reports to her, and then she interprets it and brings it back. So those are the two places. But most often, today when I scan, about 60 to 70% of the patients in my outpatient are post-CT and post-MRI. Because the CT report will say correlate clinically. And then when you do clinically, it will say correlate with CM125 for everything in ultrasound. So basically, nobody knows the diagnosis. Everybody can see, but nobody knows what that means. I'm seeing something, but I don't know what it means. That's the problem. So I think MRI has a role, but people where we can't do transvaginal scans, and she has symptoms suggesting, and in deep parametrial invasion.
Interpretation remains best.
Interpretation depends on the sonologist or the radiologist. Yeah. Imaging is in fact fantastic on ultrasound. Other than this, especially transvaginal is super. Even CT MRI, you can't look for additions. The way we can poke and say, oh, is this where you have pain? We can see, oh, these two structures are there, no sliding sign. We can do that. So definitely TVS is fantastic.
Dr. Vidyamani, Dr. Joshua Peter the lots to tell about him. He will be talking today about quality control of IVF labs. He did his PhD in human cytogenetics from the University of Bombay in the year 1978. Presently known as National Institute of Research in Reproductive Health. He was awarded the prestigious Ford Foundation Fellowship at the University of Hawaii, USA. To date, he has done nearly more than 25 years of hands-on experience in human IVF. He is credited with having set up several IVF facilities, the country's first in ICMR Mumbai and also in Gunashila Institute of Research and Reproduction, Bangalore. He has several peer-reviewed papers into his credit, and he was also recognized by WHO and was invited to be a consultant as one of the 10 leading scientists in the world. His current interest is embryonic stem cell research and pre-implantation genetics. Currently, he is the recognized PhD guide in human cytogenetics at Rajendra University of Health Sciences. Welcome, sir.
Thank you very much for inviting me to talk on the subject which has been of my interest for my whole period of 35 years, where I've been setting up labs after labs. And quality control is a must for any laboratory. Wants to start and we've already started. And, this will give you the best of results. Unless you do this, you will not be able to strive any further. In the sense, what is happening is most laboratories have been makeshift kind of an arrangement. It is not made to the way that it should be set. Because good old days, when I started work 25 years ago, I used to carry the oocyte in my pocket from Payne Hospital across the road to IRA or lab. And I did fertilize eggs, but at the same time, but of course, we were still experimenting on that. And it took almost 5 to 10 years from the time Bob Edwards first produced the best testing for us to go to a level where you could get embryos and transfer them. So now, of course, most laboratories have to have this quality control methods. Unless you do this, because we are dealing with so many instruments and so many protocols, and unless you do a thorough check of all the laboratory equipment, particularly the incubators, the laminar flow, the clean system, all that, keep a proper documentation of whatever that you do. you have to have a logbook for every instrument that you're using, and keep a check on all the temperature control, particularly in the room. The humidity control is a very important aspect. This is a lab which I set up in Astor now, and it should be convenient to personnel to work, in the sense the embryologist should not move around too much inside the clean room facility. And everything is very closely kept so that we don't move too much, and very convenient to use the facility. This is our lab. And as you know, our temperature has to be very crucial in this experiment. Unless there's a proper control of temperature, either in the room conditions where we work and the incubator, there will be a lot of fluctuations in the incubator temperature. Please, particularly when we keep the media there for the eggs and embryos, it has to be kept in a proper temperature control. Otherwise, the fluctuations of late Bob Gardner has published papers where the chromosome errors happening, and that's why you want to get these lactation. And you have to maintain 5 to 6% carbon dioxide, and that has to be properly checked periodically so that the cylinder doesn't get empty. And this room has to have a positive pressure. Class 10,000, we keep it at a particular thing so that there are not more than 10,000 particles in the air. As I said, the air quality, we should not have any fumes, micro perfumes, all that cannot be used inside the laboratory. And the high efficiency filters, both clean room as well as the laminar flow, has to be checked properly. And one thing I would like to say to you, when you buy any of this equipment, you should go to a proper person who will supply this instruments, and unless you do that, you will not get a proper results. When we enter into AMC, of any of those companies which supply this instrument, you have to be after them, because they will not come on time, they will not do the servicing properly. Even post-servicing, we have to make sure that they do the proper job, and then we have to cross-check with them if there anything that has to be replaced or attended to. So documentation is a very important aspect, and minimum opening of doors and doors for the embryologist so that you don't lose gas as well as the temperature. Make sure that these warmers are kept properly, culture dishes, all the plasticware that we use has to be properly checked and pre-warmed before we use the materials in the lab. This is our theater, the laminar flow, and then the andrology lab. And this is a warmer we use for keeping all the disposables. The cryo cans should be kept in a different area, because there's a lot of evaporation of the liquid which will not be, and it has to have a ventilator with LN2 should be evaporate. I must tell you one thing, that although this is a very dry subject on equal, with all the beautiful presentations that we had, what I thought was, when we deal with gametes, eggs and embryos, we have to be very careful. And the major part of the work is with the embryologists. And we are on the background. We don't come in the front. It's only the gynecologists who handle the patients and who and get the results. And the background where we were, I think, is the toughest job that I think people need to understand. So from the time the sperm, the gametes come to us, till we maintain get the embryos, it's our responsibility. And that being the case, we should be very, very particular that all the laboratory facilities should be functional, and any drawback will result in both mortality eggs and embryos. And then we finally have to answer the patients, which we may not do it, but the gynecologist has and Vidyamini will ask me what happened to this case which failed. Then, it's a very trying time for her to say, I'm sorry, it didn't work. For anybody, any of you who are practicing doing IVF. And so I think, although we don't get the credit for the baby we delivered, and the happiness goes to the gynecologist, they get the flowers, the bouquets, and the sweets and whatever. We are in the background, and most of this thing has to be, dealt with utmost care and precaution. Otherwise, we will not be able to deliver. So, I'm happy that I'm here today because of Dr. Vidyamini, and in the midst of all of you, that even Dr. Manisha is there. I'm happy to see her. I worked with her for a few years, and some of my colleagues are also there. So that's how embryologists work. So the credit, although I said it goes to the gynecologist, it is also shared with us, but hard work, and you must have some dedication, and you should have an aim in doing something which you might be able to improve. But unfortunately, now somebody talks about artificial intelligence and all, and most of us may not have any more jobs to do. And that being the case, I think all said and done, it's a hard work that the embryologist has to put into make things work. Thank you very much.
Thank you very much, Peter, for having honored our invitation and all that. And we do appreciate the embryologists, at least I do personally. And personally, I didn't start IVF till very late because I wanted an in-house embryologist like Peter to be there. That is the truth. Otherwise, that would have started much, much earlier. And he did a great job. And we did the first blastocyst culture in Karnataka. And he trained many embryologists in our center, like Nagaraj and all that. And he's come from the very basic, like we said, in Indian Institute of Research and Reproduction in Bombay. He was carrying the oocytes and all that even before Bob Edwards and all had started IVF and all that. He's come a long way, got a lot of experience, and he's still on the go. And he's published 2 books also, one on genetics, he's not quiet, and another one on stem cells. So, if anybody is interested in that, we really appreciate Thank you.
Thank you so much, sir. Showing us who is the foundation of all the IVF labs. I request Dr. Vidyamini to give a global message.
You give permission. Let Manisha.
Yeah.
So wonderful to see you. So nice to meet you.
Moving on to the next, last but not the least, This is a talk on decision making in surgical management of adenomyosis by our very own Dr. Haridhav KS, who has completed his BBS from DNB, PGO from prestigious KLE College and DNB from Rajiv Gandhi Government Women and Child Hospital. Completed his fellowship in minimal invasive surgery from RGOHS. Inspired during post-graduation by excellent surgical outcomes and rapid recovery, he was keen to learn the art of laparoscopy. After pursuing the fellowship degree, he has performed more than 8,000 hysteroscopic procedures, 10,000 laparoscopic procedures over the last 8 years. He is an invited speaker in various national and international conferences. His field of expertise is performing difficult laparoscopic hysterectomy and myomectomy, operative hysteroscopy, and fertility enhancing endoscopic surgery. Over to you.
At the outset, I would like to thank Vidya ma'am and the organizers for giving me this opportunity. At the end of the day, the final thing is whether we want to operate the lady or not, what should be the final decision which is going to improve her fertility or in terms of final outcome is what will be dealt today. So, according to theory, that is adenomyosis is a diagnosis on histopathological evaluation. So, there were a lot of people who used to do even a hysteroscopic procedure through which they used to pass a spiral and take a biopsy of the myometrium and identify endometrial glands, which is the final 100% full proof that there is adenomyosis in a woman. So nowadays we don't do any of those because of the better ultrasonographic or MRI based findings. The incidence is around 10% in symptomatic women and around 40% in specimens following hysterectomy. So that common the diagnosis of adenomyosis is. So as a clinician, whenever a lady is coming to you with the diagnosis of adenomyosis, what are the basic things that I need to know before I take an informed decision whether to operate or not? Depends on whether it's a type of diffuse adenomyosis or a local or a focal localized adenomyosis, whether it's an adenomyosis or an adenomyoma, whether it's a cystic adenomyosis or a non-cystic adenomyosis. See, based on all these things, our line of management also varies. The most important aspect is whether the adenomyosis starts at the inner layer, that is the junctional zone, which is nothing but the inner myometrium, and whether it's involving the outer myometrium or the middle myometrium, everything matters, because if at all I have to operate, I need to have very good topography of the pathology as such within the uterus, so that I can do a minimal damage control. If at all I am trying to remove the adenomyoma, I have to make sure that I try to remove the entire portion and at the same time not damage the normal myometrium, so that weakening of the scar is limited. So the most important aspect that I want to look for when I am sending a patient for a scanning or an MRI is what type of adenomyosis, where is its location? Is it in the anterior wall? Is it in the posterior wall, lateral wall, or in the fundus? Next thing is I would look for is the differentiation. What type of an adenomyosis? Is it a focal? Is it a mix where it diffuse with focal, or is it only a diffuse adenomyosis? The role of surgery when it comes to a diffuse adenomyosis in patients with infertility is almost zero. There are very few indications for surgery when you are going for a patient with adenomyosis. When the size of the uterus is more than 20 weeks, there are procedures where the people have done, but it's only a laparoscopic assisted open surgery, not a laparoscopic procedure. So the limited use of surgery is what you should know when it comes to adenomyosis. When it comes to focal adenomyoma, which is the adenomyoma, again the success of surgery in terms of improving the fertility is very good, but whom to operate, whom not to operate, what is the first line of treatment should always be thoroughly evaluated by a proper scanning or an MRI report. Then whether there is cystic areas or non-cystic areas, what layer of the uterus is the lesion actually located? Is it in the inner myometrium, middle myometrium, or outer myometrium? Mala madam had shown you a lot of images where it starts and then how it progresses. When it starts in the inner layer, what is the role of a surgeon to improve the fertility? Is it only medical line, or is it only surgical line, or is there any role of doing a combination? So all these things we need to have a proper clear picture in mind before I want to operate this woman. So there are Musa criteria for scanning, which again gives 9 features which helps in identification of adenomyosis or diagnosis. So these images have already been shown, so which makes my work easy. See, you never get all your patients scan done by a very good radiologist. Very few people would send their patients to get a scanning done from very good people who would evaluate thoroughly. So there are certain situations where as a clinician you cannot always expect a very good report to come out of a radiologist. So in case you want to analyze your own patient, what is the situation, you can always get an MRI done. See, as gynecologists, majority of us, what we try to do is, we just see the report, whatever is written, final impression, and then take a decision. That should never be the first thing. Don't see the report, go to the images section. Evaluate your images and then come back to the report and see if your findings that you are seeing on the images are actually correlating with it. Second thing is, I would always like to interact with my radiologist who does scan for me. If at all I have time, I can go and stand and see when they are doing the scan. So real-time analysis of the scanning is more important than getting the image. And then if I don't want somebody to tell me where I should go and then I should be driving, I want to see where I am going and I want to drive. So when I am the person who is going to drive that, I am the person who is going to operate, I need to see what exactly is the pathology. I don't want to completely rely on a radiologist's report. So I prefer to get an MRI done whenever possible, whenever needed. Whenever the case is complicated, whenever I have conflicting reports of 2 or 3 radiologists on a sonography, then I try to understand whether the report that has been given is quality, whether it's correlating with the images. Then only I go ahead with the surgery. If at all I am not comfortable, then I would like to get an MRI. MRI gives a much better picture in terms of I can go back and read the image 10 times, which gives me more information. I have multiple slices. I can get more information, like in terms of if I get a T1 fat sac images, I can get even superficial endometriosis lesions can be picked up. There are very few people who can do a very good reporting of an MRI. That is the problem. So when your reporting of MRI on which you want to operate is poor, then your surgical preparation is poor. So outcome of surgery is also poor. If you want to have a very good outcome, your evaluation should be extra thorough. I still remember I work with Dr. Nagesh from Tumkur. Every case we operate, before taking the patient to OT, we do a real-time scan we reconfirm our findings and then go and operate. That gives a better understanding of the pathology and then better understanding of what has to be done. We replan the surgery. So planning is the key for a success of the surgery, where how you evaluate the patient matters. So basically, MRI study should be done in the late proliferative phase because, like how Madam said, there can be changes that can happen. So early proliferative or late proliferative phase or post-menstrual phase is the time when you do an MRI, because junctional zone, everything can be evaluated in a much better way. This is an image of generalized. The entire uterus is involved with cystic adenomyosis. And then this is the evaluation of the junctional zone. So basically this is the increase in the junctional zone when you have a patient with adenomyosis. So what are the treatment options? Since I have already told you the role of surgery in a patient with infertility having adenomyosis is very limited, I will talk about general adenomyosis as such in any woman, what are the treatment options. So the final definitive treatment for any woman is a hysterectomy, because that is the final cure for her. Then the other options are ablation, resection, then excision, adenomyomectomy, either you do by laparoscopy or by laparotomy. Then hysteroscopic excision. What is hysteroscopic excision? There are subendometrial cystic spaces which can be evacuated, and then if need arises, you can even resect them. So that after that you do HRT so that the endometrium grows over it. So such procedures can also be done. There are procedures like uterine artery embolization and all those, but for patients with infertility, you never choose. These are the. So what are the steps of a hysterectomy? So whenever we plan a patient for surgery with adenomyosis, standardizing the steps of surgery is key for the complete success of the surgery. So we have few steps of the surgery which I would like to show through a video. This was a patient who had a rectal nodule on MRI, and then she had a focal adenomyoma of the outer myometrium. You can see the ovary is stuck, and then you have a left ovarian endometriotic cyst, and then you have a rectal nodule. So the same patient, we did scan, I did an MRI, and then went and operated. So the surgery starts from the pelvic brim. It's not inside the pelvis, it starts at the pelvic brim. Identify the ureter first, because they are the guiding factors. The entire surgery, you can notice that the uterus is anteverted, pushed somewhere, and it is directed towards another side, and then the ovary is fully stuck. So the first step in surgery is identify the ureter. Lateral to the ureter is always the infundibulopelvic ligament. So I am cutting the round ligament, and then this is the mesosalpinx where there is an hydrosalpinx. Because of the hydrosalpinx and there is a nodule here, the mesosalpingeal vein also is enlarged. So you have to open up the peritoneum, isolate the vessels. So this is the infundibulopelvic ligament which I have coagulated, and then the entire adnexa is taken. So you have to, because there is clouding of structures in the pelvis, the first step is always declutter it. Next is the UV fold. I have pushed the bladder. The next step is you can see the uterus being here, and then the rectal nodule. So the rectum is actually stuck to the uterus. So the next step is open the pararectal space, then start dissecting the nodule. We incise the nodule, and then the next step is skeletonization of the uterine artery and release of the uterine artery. Once you release the uterine artery and give a incision, then Meckel rods are opened, and then finally it is the colpotomy. So once you do that, the specimen comes out by vaginal morcellation. Once the specimen comes out, the next step is not closure of the colpos. So what we do is all the endometriotic lesions or fibrotic lesions which can be causing symptoms to the woman are all excised. Here rectal nodule which was incised, that is removed. Next the rectal adhesion to the vault, that is also released, and then you have a nodule in the uterosacral ligament, that is also excised. Once excision of the uterosacral nodule and whatever fibrotic bands are, then only we go ahead with the closure of the colpos. Here I would like to suspend the uterosacral ligaments so that the chance of wall suspension is less, and then rectal integrity test. If required, you can do a cystoscopy. If required, you can even do a prophylactic stenting also. So standardization is the key for success of surgery. So what are the features of adenomyosis when you do a laparoscopy accidentally for a diagnostic histolab? So generally the uterus is enlarged to more than 9 centimeters, spherical shape, soft doughy uterine walls are seen. Then you can see on the marbled appearance of the vessels on the surface of the uterus, and when you do a chromoperturbation you can see intravasation of dye into the myometrium, which will appear like a blue site. So these are all small features which helps you to identify adenomyosis, because you don't get a very good reporting all the time. This, I think part of this was covered by Madam in her slides. What is the difference between a myomectomy and an adenomyomectomy? Majority of the times we don't get the diagnosis of adenomyoma. It is always given as a diagnosis of myoma, and then when we go in and see, we get to know that it is not myoma, it's an adenomyoma. Again, the same principle, we have released the ureter, and then the ovary which is stuck there is now also released. The ovary had a cyst, chocolate cyst, which was evacuated, and then the ovary was free. The most important aspect for this woman is how can we improve her fertility, if at all. So you can see superficial outer myometrial lesions of adenomyosis here. These are the cystic lesions in the outer myometrium. This is the rectum which is stuck to the posterior aspect of the uterus, and then the rectal shaving also will be done. So the rectum is released. Here it is very densely stuck to the torus. So I am using the scissor to release the rectum. Then the next actual part of the surgery, that is the adenomyomectomy start. The special feature of adenomyoma is as soon as you give vasopressin infiltration, there will be focal whitening of the uterus. Whereas when you have a fibroid, the entire uterus becomes whitish. So that is how you identify whether it's a fibroid or an adenomyoma, because your scan is not reliable. Then I would prefer to use a scissor whenever possible, so that the feel of the tissue is there with my hand. So this haptic feedback tells me whether I'm cutting the adenomyotic tissue or a normal myometrium. Whereas when you use a harmonic or a monopolar hook, that feel is not there. It's not a mandatory step, whenever possible. And never try to remove the entire adenomyoma in one go. You can take out in small bits so that you don't try to damage the remaining myometrium. Here the cystic portion of the outer myometrium, that lesion also is taken out. And then the most important aspect is the suturing. I'm concentrating more on showing you the suturing part, because finally the integrity of the scar depends on how well you are able to obliterate the dead space, avoid any kind of bleeders within the myoma, adenomyoma bed where you are suturing, and then see how much of tissue has been taken out, and then what is the depth that needs to be sutured. Whether you suture in 1 layer or 2 layer, doesn't matter. Obliteration of the space. And here using a barb suture gives me advantage that there is no retraction of the tissues, and the tension-free suturing is always there. So the wound healing is always better. We prefer to put a adhesion prevention barrier post-surgery, because adenomyoma and myoma, if the myometrium is exposed, the chance of adhesion when it happens, it will be a very dense fibrotic adhesion. So if at all bowel adhesion happens in any other condition, it will be flimsy. Whereas following myomectomy, adenomyomectomy, when the myometrium is exposed, the adhesion that forms with the bowel or any other visceral structure is a dense adhesion. So we don't want any dense adhesions to happen, because adhesive lysis, for whatever reason, whenever she goes for a hysterectomy, will be very challenging. Once I remember recently I was called for a cesarean section for a central placenta previa by my colleague, and we had prepared, okay, we will do like this, internal iliac ligation, everything. We were not able to exteriorize the uterus at all. She was a patient of severe endometriosis with adenomyosis who had conceived with IVF, and the entire posterior aspect of the uterus is stuck. I am not able to exteriorize. Luckily that patient didn't have PPH. Had she had PPH, once I pulled out the uterus out of the abdomen, I am seeing the entire rectum stuck and patient is not prepared, bowels are not prepared. If she starts to bleed, whether I have to do an internal iliac artery ligation or get a better exposure so that I don't have any injuries to the ureter. So that's a challenge. See, we always look at, okay, she should become pregnant. That is the end of the story. But whether her pregnancy will go well, in case she has an obstetric complication for which I have to operate, she's torrential bleeding, I am looking at adhesion and I don't have an access to internal iliac artery. So, lot of situations arise, no matter how well we prepare and go for the case, sometimes there will be challenges that we can face. So, it's always a learning curve. So, always prepare in a much better way so that your surgery goes well. So, what are the outcomes of surgery? This is what we are interested in. When it comes to pain, we are doing surgery for pain or AUB in terms of HMB, the success is very good. When it comes to fertility, again, if you are doing surgery in a very select number of cases, the improvement is there in terms of fertility. What is the impact of surgery on the pregnancy part? There is an element of miscarriage which is not related to surgery, but there is an element of preterm delivery, because whenever you are doing adenomyomectomy, it is not just the pathological tissue that you are taking. That pathological tissue is nothing but myometrium. So the volume of the myometrium in the entire uterus is reduced. So the capacity of the uterus to expand also is reduced. So there is a possibility that she can end up in a preterm labor, because in myomectomy, you are not removing normal myometrium. Whereas in adenomyomectomy, that lesion is nothing but a hyperplastic myometrium. So you are reducing the volume of the myometrium in the uterus. So there is an incident probability of having a preterm birth and then uterine rupture. So uterine rupture again depends on what was the size of the adenomyoma, how good the integrity of the scar that has been given, was it an ideal case to have operated, who operated. Especially when it comes to laparoscopic procedure, 3 surgeries should be operated only by experienced people: myomectomy, adenomyomectomy or endometriosis surgery. These have to be operated only by senior people, because the entire pregnancy or her results depends on how good you can give a very good integrity in the scar. So the thing is, the reason why I showed the suturing was, we at the outer layer of the myometrium, we do a baseball suturing so that the myometrium gets inverted and only serosa to serosa is seen outside. When there is serosa on the outer surface, the chance of adhesions are less, and when the entire myometrium is going back to its normal position, the strength of the scar is good. Make sure that there are no bleeders or small hemorrhagic spot, blood clots inside the womb, so that the strength of the scar is maintained. This was another lady who came with primary infertility. Her complaint was basically dysmenorrhea, and then when the scan was done, it was shown like 2 cystic lesions were there, and this is the endometrium. So the lesions were adjacent, almost like wherever the round ligament is. So the lateral part of the uterus. So I'm sorry for the poor video, because there was a problem with the rendering of the video. You can see this lesion here adjacent to the uterus. We just gave a little bit of vasopressin infiltration, and then with the hook we are giving an incision, and I can see that cystic lesion there. And so this is a kind of uterine malformation which is also very common. So accumes are usually in the lateral aspects where the round ligaments are attached, and these are cystic lesions. So there is a functional endometrium inside that cystic area, and don't give medical line of treatment. This is what I wanted to tell you. So the line of treatment is surgery always for such lesions. The dysmenorrhea immediately goes away for such women. So what is the role of hysteroscopy in adenomyosis? As you all know, the disease starts from endometrium going towards the myometrium. So the inner myometrium, the way you can identify is either by a scan, and whatever therapeutic procedures you can do is by hysteroscopy. There are a lot of women who would undergo a diagnostic hysterolaparoscopy with someone else's report which is not fully evaluated. So you say, okay, you have a problem, we'll do a diagnostic histolaparoscopy. But what are you going to look for if you don't know what pathology the patient is? So recently in the last week conference I had shown you will have entire cavity filled with brownish fluid. So that is the first feature which tells there is an element of adenomyosis. And in this lady, she had a small polypoidal cervical polyp, and then you could see a lot of brownish fluid in the cervical canal, which tells that probably she has an element of adenomyosis. When we went in, you could see hyperplastic polypoidal endometrium, which is irregularly grown in multiple places, and then you have the brown dots. This is nothing but the deer spots, which are characteristic of early stage adenomyosis, which is happening, which is going. You don't need to operate too much on these women. Just get the polypoidal endometrium out and then give them GnRH analogs. You can see this posterior wall is actually soft and boggy. Then this was another patient before embryo transfer. She was asked to undergo hysteroscopy because there was fluid in the cavity. And then when we went in with the hysteroscope, you could see a discharging sinus. So the treatment is very simple. Just open up that sinus, let out all the fluid, and if required, you can even ablate or you can just coagulate that sinus tract and then give her HRT. The endometrium grows very well. This is another patient whom, for AUB with a thickened endometrium, we did a hysteroscopy. You can see irregularly grown endometrium with crevices and then subendometrial blood clots. And she also had a small polyp in the uterine cavity, which is a simple endometrial polyp. So again, the treatment is simple. You do whatever therapeutic, instead of doing the blind D&C, you do a hysteroscopy, identify the pathology, try to evacuate. Here subendometrial bleb, whatever was there, it was cut using a scissor, and then the polypectomy was done, and the therapeutic curettage was done. And then you can offer her a Mirena, which gives very good results. In case none of these work, then you can plan for a definitive procedure like hysterectomy, which is always available. These are some images. So this is what I was talking about, Osada. He is a Japanese surgeon, he's a Osada. He was the one who did the surgery for debulking surgery when you are doing a patient is having a 20-week size uterus with adenomyosis, wanting to have a fertility. It's a laparoscopic assisted open surgery. The triple flap technique surgery is done. The results are very promising according to the paper that they have published. And quite a good number of people, when you are doing the selection of the cases and doing the surgical technique in the right way, I think even the pregnancy rates are good with this technique, but not for everybody. So the take-home message is, misdiagnosis is common. I am talking as a person when I see reports from multiple people. I don't think we get all the reports like madam. There are few people who have a proper training, so their reports are reliable. So that diagnosis is one part, whether to operate or not is another part. So getting the correct information is very important. Either you do an USG or an MRI. We are not that critical, okay, only USG is sufficient or only MRI. As need and basis, you get whatever is going to give you good information so that you can take a better decision. Role of surgery in adenomyosis for fertility is very minimal. Coexisting conditions like uterine malformation should be thought in mind, endometriosis and myoma. I thought it's just a 15 minutes, so I didn't put another video where I was called for a surgery where she had multiple myomas. Uterus was around 18 weeks old. We started removing the myomas one after the other. Then I saw a lesion in the fundal area. As soon as I gave vasopressin infiltration, I said, this is not a fibroid, this is an adenomyoma. I started resecting. Because I was not given the right information, my resection went up to the endometrium. But the thing is, there is no harm even if you open up the endometrium. It's still okay because you know where your boundaries are. Once you know the boundaries, give half centimeter margin and then start resecting all that is required and then leave the endometrium. Don't take endometrium in your sutures and then make sure that there is no hematoma, good closure if you do. Definitely patient's endometrial cavity is not damaged. At the end of 3 to 6 months, you can do a relook hysteroscopy in case any adhesions have formed. If at all any flimsy adhesions have formed, you can use a scissor and cut off those adhesions. And her fertility will be better following such procedures. Next is, whenever you are doing it for a patient with AUB, you have to standardize the steps of surgery. I have had multiple encounters. They will tell, sir, it is just adenomyosis. Sir. I say, adenomyosis means there is an element of endometriosis. Always rule out, is there any uterosacral ligament hypertrophy? Because you don't get a very good report, do a good examination. All you have to do is a per-rectal examination, see whether the uterus is stuck, whether the uterus is mobile or not. All those information gives almost very good information to you, which is required for a surgeon. So better preparation, so you can do a better bowel preparation for the patient, so that in case accidental bowel injury happens, primary closure gives very good results. So for success, you have to standardize your own surgical steps, and when there is acute, there is no line of medical line of treatment. Thank you.
Thank you, sir, for sharing the tips and tips about the surgery. I request Dr. Shaliman, anesthetist, to come and give a token of appreciation. Thank you, sir. Now I request Mr. Shamsuddin, Manager Public Relations of Sagar Chandramma Hospital, to thank the sponsors, Inca Life Sciences Transformative Division. Please come.
I just wanted to say for ACOM now we do sclerotherapy. So, but the problem is that if you're doing it without GA, the patient will not be able to bear the pain. So we do it in OT, and there's an article by Dave Tabor, and he does a lot of them. So we've done a few now. We put in a needle, we drain out the ACOM, and we leave a little bit of alcohol there. Yeah, ethanol there, and it's supposed to prevent, because they say anyway, if you can do a simpler technique with no cut, it's a better thing. So I'm just saying the only problem is that there's a 15% recurrence. So it's not, you have to tell the patient about the recurrence rate. So there's 80 to 85% success only in literature.
Now when we say about recurrence, patient wants one-stop solution.
No, but I tell you, most of these girls are young girls. So why I tell you is because none of them want a scar. Many of them are unmarried young girls, 19, 20. So if you tell them that we will give it this a shot, if it works great, you can avoid surgery. So that's how I'm saying. I mean, obviously, if they don't agree, then you have no choice. But I just thought I should let everybody know that this is an option now.
Thank you. Thank you to Inca Life Sciences, the Transformative Division. Next is Lifestyle. Winston Life Sciences Private Limited. And this is from Rama. Now I call upon Dr. Sudhasini to give the vote of thanks.
Distinguished guests, esteemed speakers, chairpersons, and fellow colleagues. It is with immense gratitude and a sense of fulfillment that I stand before you today to deliver the vote of thanks for this remarkable CME on IVF and infertility. Over the course of the day, we have witnessed an exceptional gathering of experts in the field of infertility who have shared their knowledge, experiences, and enriching our understanding. First and foremost, I would like to express my deepest appreciation to all our esteemed speakers and chairpersons who have graciously shared their expertise and insight and for smooth conduct of the sessions. I would like to extend my heartfelt gratitude to Sagar Chandramma Hospital for giving us this opportunity to host the CME and their constant support. To our sponsors, Sun Pharma, Lifestyle and Instant Licenses, we extend our sincere appreciation for your support and contribution to this conference. I would like to acknowledge to all our delegates your active engagement, insightful questions, and meaningful discussion which have elevated the quality of this conference. I would like to express my gratitude to the venue staff and technical support team who have worked to ensure the smooth execution of this conference. At last, I would express my deepest appreciation for Dr. Vidyamati and Dr. Lata, who have tirelessly efforts and excellent planning and made this conference a resounding success. As we conclude this conference, once again, thank you for all your invaluable contribution and for being a part of the CME. May we meet again in the future, united in our pursuit. Thank you. Thank you, ma'am. May we meet again in the future, united in a pursuit of excellence and a shared commitment to improve women's health. Thank you, and please kindly join for the coffee lunch.
Lunch at first floor.
Lunch at first row.
ಇದೆಲ್ಲ ಯಾರು